Assalamu alaikum. Today's topic is emphysematous pyelonephritis. Emphysematous pyelonephritis is a life-threatening necrotizing infection of the renal parenchyma and perinephric tissues characterized by gas formation within the kidney collecting system or surrounding tissues. So, it's the gas forming necrotizing infection of renal parenchyma. It's a life threatening condition. What are the risk factors of emphysematous pyelonephritis? The most common risk factor is diabetes mellitus, 80 to 95% of all cases. Next one is obstructive uropathy. It may be due to stone, stricture, etc. What are the other common risk factors? That is immunosuppression, female sex, neurogenic bladder, and CKD, which increase mortality. What are the causative organisms of emphysematous pyelonephritis? Most are gas-forming gram-negative organism. E. coli is the most common organism. What are the others? Klebsiella, Proteus, and less common Pseudomonas and Enterococcus. What are the clinical features in case of pyelonephritis? High-grade fever, flank pain, nausea or vomiting, and dysuria in sometimes. That is triad of pyelonephritis. We know that fever, flank pain, nausea, and vomiting plus minus dysuria is the triad of acute pyelonephritis. In case of emphysematous pyelonephritis, the triad, that is high grade fever, flank pain or renal angle tenderness, and nausea and vomiting, all are present. In some cases, dysuria may be present. Patient may present with complication, that is sepsis or shock, sometimes acute renal failure and acute altered level of consciousness. Crepitations may be found over flank. It is rare but very classic. How can we diagnose it? The gold standard is non-contrast CT QB. The findings are gas in the renal parenchyma, collecting system or perinephric space. It helps to classify and treatment decision. What are the other investigations that we can do? That is complete blood count. We found leukocytosis, renal function test, raised creatinine in case of AKI, liver function test may show ischemic hepatitis, urine culture positive in 70 to 90% cases, and blood culture often positive. How can we classify it according to CT scan? Class 1, if gas only in collecting system, that is called emphysematous pyelonephritis. If gas in renal parenchyma, it is class 2. If gas in perinephric space, 3A. If gas in pararenal space, then 3B. And if bilateral emphysematous pyelonephritis, it is class 4. Higher the class, higher the mortality. How can we manage it? Medical management always start immediately as it's an emergency. IV fluid, broad spectrum antibiotics, that is piperacillin, tazobactam, meropenem, preferred in critically ill patients. Sometimes aminoglycoside or vancomycin may be added with this. Strict blood glucose control and hemodynamic support if patient is in shock. Surgical treatment or depends. Surgical treatment depends on CT classification and clinical condition. Percutaneous drainage can be done. In case of class 1 to class 3 with hemodynamic stability can cause percutaneous drainage, and if there is any obstruction, then percutaneous drainage may be needed. What are the indications of nephrectomy? Failure to medical treatment or percutaneous drainage, class 3B or class 4 with multi-organ failure, severe shock, acidosis, raising lactate, and non-functioning creatinine. Actually, mortality is higher if nephrectomy is delayed in unstable cases. What are the poor prognostic factors? in case of emphysematous pyelonephritis, thrombocytopenia, AKI, shock, altered sensorium, hypoalbuminemia, and bilateral presentations. Follow up. How can we follow up the patient after starting treatment? Repeat CT scan in 5 to 7 days or according to clinical condition. Continue antibiotics at least 2 to 3 weeks. Control diabetics for long term and manage stone and obstruction if present. What are the take home messages in emphysematous pyelonephritis? Emphysematous pyelonephritis with diabetes is an emergency. CT scan is the gold standard treatment. E. coli is the most common organism. As soon as possible suspected with emphysematous pyelonephritis, start treatment with IV antibiotics. Drainage sometimes needed. Nephrectomy is needed if patient is unstable or non-responsive. Mortality is high but improves with early percutaneous drainage and ICU care.